Assalamu alaikum. Welcome everyone on board. Uh, we had started uh, airway management. Okay. So anyone who attended the class yesterday or any question related to airway management before some more people join. Am I audible to you?
Yes, sir.
Okay. So yesterday we covered some of the aspects with reference to airway management. I will just try to give some more. Please keep your mics muted. Okay. Dr. Pradeep, stop your video. Okay. So I will just try to give because yesterday we had started and we discussed some of the important points with reference to airway management. Now I'm just starting with something different. For example, if you have a patient with myasthenia gravis for airway management, okay, what do you think? What is the difficulty in airway management of this patient? Please speak out. Yes, Shoaib.
Sir, weak muscles.
Be weak muscle. So what is the problem with reference to airway?
Sir, there will be problem in the mouth opening.
No, wrong. Bulbar weakness. So what will be the problem with bulbar weakness? Anyone, please. Whenever there will be bulbar weakness, there will be risk of aspiration. Okay. So whenever there is risk of aspiration, you need to have something not to ventilate too much. Then another problem here will
Sir,
be un
please repeat.
whenever there is bulbar weakness in myasthenia gravis, there is bulbar weakness. Okay. So when there is bulbar weakness, there is risk of aspiration. Okay. So if there is risk of aspiration, actually you don't want to have too much ventilation. Okay. Like you want to have rapid sequence induction or modified rapid sequence induction with airway pressures less than 15 to 20. Okay. Centimeter of water. Oh, okay, so then another problem here will be that there is alternate response to neuromuscular blocking agents. So then the problem will be that if you give suxamethonium, what is the effect of suxamethonium in myasthenia gravis? Nobody.
Sir, there is a resistance to dexamethasone, so high doses of dexamethasone is required.
Okay, and if we give high dose,
Sir,
then what is the problem?
there will be hyperkalemia.
No, dual block.
Sir, there will be second degree block.
Effect will be prolonged.
This is phase 2 block. This is called as phase 2 block. You have to be specific. It's not prolonged effect. Prolonged effect is something else. Okay. Prolonged effect is because of like pseudocholinesterase deficiency. So that is something else. Okay. With reference to that DPOK number and decreased activity of pseudocholinesterase. So if you give atracurium, it is sensitive and you usually need 1/10th of the dose. Okay, like it will be very sensitive. So like just a small point that in when you are doing a case with myasthenia gravis, then another problem is that if you do rapid sequence reduction, there is another problem in this case is that there may be autonomic involvement. Okay, so the patient may respond suddenly to the anesthetic agent. So this is with reference to myasthenia gravis. Rheumatoid arthritis. What is the problem in rheumatoid arthritis with reference to airway?
Sir, atlantoaxial subluxation.
Very good. One thing. So now what you cannot do, you cannot have neck mobility. Neck range of movement will be decreased. What else? Please continue.
Team J movement, sir.
TMJ ankylosis. Okay. So there is limited mouth opening. Anything else?
Sir, cardiac issues with the rheumatoid arthritis.
Like you can, if someone asks you, you can say multi-systemic disease. So there is multi-systemic disease with so many problems. So there may be problems related to muscle relaxant. There will be problem related to induction agents. So now what is the solution? Awake fiber optic. Okay. If there is mouth opening, then glidoscope. What is actually the blade of glidoscope is like this. It is quite angle is quite acute. So it is very easy to intubate with the glidoscope. Okay. So glidoscope is an excellent device for airway management. Then another thing that you can have inhalational induction. Okay. Inhalational induction. So awake fiber optic, glidoscope, problem with the neck mobility. So glidoscope will avoid the excessive movement of the neck. Okay. You don't need to extend the neck too much. Like you don't need to have this elevation because of atlantoaxial subluxation. You don't want to move the neck a lot. Okay. Okay. So pregnant patient. Challenges in pregnant patient. Please. There is
Difficult airway due to
difficult airways there. What is specifically? We all are discussing difficult airway. There is decreased FRC. So easy desaturation. Number one.
desaturation.
Then there is risk of aspiration because of gastroparesis.
Full stomach.
Gastroparesis. Then third thing, the enlarged breast tissue problem in the laryngoscopy. Okay.
Edematous mucosa, sir. Edematous mucosa.
Edematous mucosa. Very good. So what is the solution? You will do the ramp position to have the ease in laryngoscopy. The breast tissue will be it will displace the breast tissue and rapid airway management position. Okay. I had showed in the previous discussion. Then you will do the pre-oxygenation. Okay. Before that, acid prophylaxis. Actually, acid prophylaxis need to be mentioned also with reference to this one, myasthenia gravis. Okay. It also was to be. So you will do the ramp position, pre-oxygenation, and then rapid sequence induction or modified rapid sequence induction. Okay. So this is and then yesterday we discussed that, for example, if there is failed intubation, still you might need to proceed with the case if there is fetal distress. Okay. If there is no fetal distress, then you can awake the patient and can have alternative ways. Okay. Either regional anesthesia or with an alternative plan. But if it is fetal distress, even with the LMA, if you are able to ventilate, you will proceed. Okay. So this is something a little bit different. What about pediatrics? Very good. What is the problems with pediatrics? Large head. Okay. Large tongue. Occiput.
Sir, anterior
Large-
larynx.
Very good. Anterior larynx. I'm sorry, just one thing I just hear with reference to edematous mucosa, you will use the decrease endotracheal tube size. Okay. Decrease endotracheal tube size. Then with pediatrics, large head occiput, large tongue, anterior larynx, and then the funnel-shaped trachea, funnel-shaped airway. So the cricoid, can you mute the mic, please? It's too much noisy. Okay. So the cricoid cartilage is the narrowest point. So tube may pass through the glottis, but may stuck beyond glottis. Okay. So there is subglottic. You can
There's
stick there.
decreased effort.
Yes. Also decrease FRC, then increase oxygen consumption. Okay. And another thing is that
Large body area to surface ratio.
I'm sorry.
Large body area to surface ratio.
Yes. This is large head. Okay. So all these like increase oxygen consumption, decrease FRC, less compliant lungs.
Sir,
So
kindly
result,
ask Dr. Pradeep to mute the mic.
I'm sorry.
सर डॉक्टर प्रदीप के माइक से थोड़ी डिस्टॉर्शन ज्यादा आ रही है.
Yes. I know. What can I do? I'm requesting him to mute the mic. Anyways, I'm just giving you an idea, okay? Because difficult airway, there is no exam which will be finished without difficult airway, okay? So I'm just giving you a cross-sectional view into different diseases and how difficult airway will present and how to manage, okay? So now again that you will always anticipate difficult airway, okay? Always anticipate difficult airway. Again you will pre-oxygenate, okay? Then you will try to what's okay, you will have some in especially in neonates, people use straight blade, though I hate it. I never feel comfortable with the straight blade. But anyways, you just need to have a good pre-oxygenation anticipation. You can put something under the head, which makes laryngoscopy a little easier. Okay. Like a small roll under the head makes the laryngoscopy a little easier. Okay. And again, um, because there will be chance, if there is hypoxia, there is sudden bradycardia and cardiac arrest. So it is better you can give some glycopyrrolate or atropine. Okay.
Sir, roll should be under the head or under between the shoulders.
Under the shoulders, for what will happen with the shoulders?
Sir, it will be more easier for the airway to get aligned because the head is bigger now. So by raising the shoulder, we will be able to intubate it easily, as I have seen in my practice.
Maybe I have a little bit different concept. We can discuss this thing. Okay. I appreciate your point. I got your point. Let me confirm it. Okay. Because I think we put something under the head, not under the shoulders. Okay. Because the purpose is the same. You want to have a better view with the laryngoscopy. Okay.
Ji.
Okay.
I
We
think
will
the problem,
yes,
can I
yes.
just say, I think the
Yes, sure.
problem is just because we feel that when there's something under the head, it will flex the head, and since we are standing behind the patient, so a flexed head means we have to bend all over the patient to see inside. I think that's why we feel it should be under the shoulder, so it raises the patient and extends the neck, so we are able to
Yes.
see more clearly standing behind the patient. But
Actually,
you're right.
you
Yes,
are
go ahead.
absolutely right. Actually, the purpose is to make, there are actually three angles: oral angle, pharyngeal angle, and laryngeal angle. We want them to be aligned to make it in a funnel, just to make the laryngoscopy easy. Okay, so this is the purpose. So I can reconfirm because we have short time. If the I will reconfirm, Imran. Your point is absolutely valid. I will reconfirm exactly what should be the
Yes,
words. Okay,
yes,
I will reconfirm it. Can you mute your mic, please? It's very distracting. I request all of you to please mute the mic. Okay. Okay, so I will just I was just trying to give you some idea about some of the diseases. You can again like make we can do practice a little more diabetes mellitus. Okay, there is glycosylation of joint, so there may be difficulty in laryngoscopy. Okay, then patient with Down syndrome, like any pediatric patient, Muhammad Ali, you are writing with the screen. Who is writing this one? Okay, so Down syndrome again, that is the points which we discussed. In addition to that, you might need to have less size of endotracheal. Okay, so again, some other conditions. Let me think. Difficult cleft palate, cleft lip. Okay, there is problem with the mask ventilation. Okay, you are not able to have the mask ventilation. So practically speaking, what we can do, that again glidoscope can help, and we can put a gauze to cover the area. Okay, so that the gas is not leaked through there. But some people will say inhalational induction. Okay, with preservation of spontaneous ventilation. Okay, again with obese patient, the same principles like pregnant patient almost. So like you can have ram position, you can, and again as I mentioned that maybe bag mask ventilation is more problematic than this one intubation actually sometimes. Okay, but of course maybe this glidoscope, okay, or video laryngoscope may be helpful, or if you have any doubt, you will go for awake fiber optic. Okay. Some other disease, can anyone just recall some of more diseases which we can discuss? We have discussed rheumatoid arthritis, myasthenia gravis, diabetes mellitus, pediatric difficult airway, pregnant, elderly. Okay, elderly patients again have almost the same problem and mainly edentulous. So there is problem with the bag mask ventilation. Okay, again fragile area. Even there is one category in which there will be edentulous, and other category in which we have large head and serum. Okay. What are the messages? Okay, yes, very good. Burns. In burns, again, the problem will be with the succinylcholine use. Okay, and the other problem will be with the contractures, if it is redo problems. So again, the answer can be awake fiber optic if there is any limitation in the or otherwise. Again, if you have any doubt, inhalational induction with preservation, as I mentioned, is a technique which you can practically save. Okay, and even in the exam, your answer will be safe. Okay. Yes, facial trauma actually, if there is a problem like in which base of skull is involved, like in Lee 4-3 type. Okay, then it will be tracheostomy. Okay, if you have any problem like that, and in some conditions there is one technique which is called as submental intubation. In some surgeries, when they have to do the surgery, and the air this tube will be in the way, so what will they do? They will do the normal intubation, and then they will create a tunnel from which the tube will come out, and it will be attached to the breathing circuit. Okay. Again, remember one thing, in some of the conditions, nasotracheal intubation will be needed, especially if you have dental surgery, okay, tonsils, okay, and a number of maxillofacial uh, procedure, maxillary surgery. You need to have nasotracheal. Yeah, actually, thyroid we had discussed yesterday. We will repeat again. Just a second. With reference to nasotracheal intubation, you should be confirming nasal blockade. Okay. You should use nasal decongestant. Okay. Before, and don't, the basic rule is that don't push the tube hard. There is a special silicone tube which is recommended. Unfortunately, it is not available all the time, and people are using the normal tube, but it is never safe. Okay. So there is a problem with this thing with thyroid. Okay. So actually, thyroid we discussed before yesterday as well. I will just quickly repeat. If there is any doubt, your answer should be awake fiber optic. Okay. Other safe, relatively safe answer will be again inhalational induction with preservation of spontaneous ventilation, ramp position, check laryngoscopy. Check laryngoscopy, and if you are able to visualize, then you can give the muscle relaxant or this one like propofol or any induction agent which can cause apnea. Otherwise, you will not. If you are doing laryngoscopy, you are trying to do the induction and you fail to intubate and fail to ventilate, and you think that it is because of obstruction, as I told yesterday, you will try to turn the patient on the lateral. Okay. You will turn the patient on the lateral, and or you will try to relieve the obstruction by lifting the swelling. And the third thing, that because in anticipated difficult airway in which you can have problem, you should have ENT surgeon on board here, not for tracheostomy, here for doing rigid bronchoscope. Okay. Because sometimes you are not able to ventilate because of the compression. The condition is called as tracheomalacia. Okay. In the long standing thyroid, there is incidence of tracheomalacia, and as soon as the consciousness level is deteriorated, patient airway may collapse, and airways like tracheal rings are already damaged, and you are not able to ventilate. So in that scenario, as I told, lateral position, lifting the swelling, or rigid bronchoscope. Okay. So I think okay. Okay, so I will just show you few of the articles which I was just finding interesting. Um, just a second, please. Yes, this was article I just found with reference to, actually it is with reference to pediatric airway management, but I just liked it. I will just show you, as we discussed, pediatric difficult, large occiput, epiglottis, vocal cords are angled more anteriorly. Okay, decreased subglottic diameter and stenosis, as I mentioned you. Just a second, please. Okay, and larger percentage of narrowing of airway with some degree of edema, cone shape, we have discussed, burden of stocking. So uh, they have mentioned some of the special categories in difficult airway. Just a second. Let me see anything different which we did not discuss before. I think there is nothing different. Just a second, please. This is just a sort of some of the anticipation, preparation of difficult airway trolley. Okay, and because another challenge in a number of patients, actually you are doing an inhalational induction intentionally because there is no IV line, and pediatric patient will not allow you to have a IV line. So my question, one question, if you are not able to take the IV line, okay? If you are not able to take the IV line, should you try to intubate or put LMA or no? Yes or no?
Yes, sir.
No, sir.
Sundas,
Yes, sir. Yes, sir. Yes, yes.
Yes, sir.
just a second,
Yes,
just a
yes,
second.
bro.
No, 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 no.
No, sir.
Remember,
Sir, we
remember
will
one thing.
take IV line with inhalational induction
Yes, we should
with
never
giving SIBO.
ever, if the patient is breathing, okay, and you are able to have good ventilation, either with spontaneous or you are able to ventilate by hand, by your back, never try to have airway manipulation without IV line. Never ever try this. Because once you try to manipulate the airway, there will be chances of patient going in laryngospasm. There may be chances of patient having bradycardia because of vagal stimulation, which is vagal tone is too much in pediatric. People think that there is only a tachycardia. There are more chances of vagal reflexes, even with laryngoscopy and even with intubation. So never try to intubate unless you are losing the airway. That is something else. If you are not able to take the IV line and you are losing the airway, patient, you are not able to have the ventilation, saturation is going down, only then you should try to intubate or put LMA. Otherwise, no. Okay. Any counter arguments?
No, thank you, thank you.
No, sir.
Okay, Yusra, you are from the children hospital. So Sundas,
Ji, sir.
correct your concept. Okay, we
Ji,
have a
sir.
pediatric
Thank you, sir.
Okay. Anyways, so rest of the thing I was just seeing here cards. Okay, so actually this may be a question in your TOEIC exam, or this may be a question in your dedicated difficult airway trolley. Okay, so they have just mentioned few of the things. Top work surface, 4 or 5 drawers that follow the sequence of difficult airway algorithm, mobility, robust construction, clear labels, preferably with pictures, easy to clean, reproducible, attached document, difficult airway algorithm, restocking. They have just actually these are very simple things. But if suddenly they will ask you what is difficult airway trolley, then you will be thinking what is it? Okay. So just it is nothing special. That same thing, but they have just made it lame. And because somebody was asking to Dr. Fazal yesterday in the morning that what can be the new advances or new things so these are sort of things. This is not something new, but this will be something atypical. Like we remember that once upon a time, 10, 12 years ago, rapid response team, RRT, was a question which nobody knew. Okay. So suddenly they were asking rapid response team and nobody knew about it. Okay. So this is one of the things which you should, that's why I always request all of you to have a look on the new articles. Okay. So Imran, you were right. I think you see they have written here shoulder roll. So I I I take Iman on this word now. Okay. Before IV line, yes, Yusra, can you have a comment? There is a question that can spinal be administered before IV line in children? I don't think so. Okay, but I think Yusra, she's here, so we can ask what's their routine in children hospital.
No, sir, we cannot do anything without IV line.
Okay, so
We
thank
go
you
for
very much.
IV line.
Yes. So this is true for IV line. Without IV line, no many because if suddenly what will you do? Yeah, there will be some counter argument. Some people can say that you can have intramuscular atropine and then you can try, but don't try unless there is a strong compulsive indication. Okay. Yes, some advancement others let alone children like this. Who somebody raised their hand? Anyways, okay. So just a second. Resource management. You can have, I will share this article with you. So I just found it a little different. So I just show you. They have just arranged in a way the supraglottic airway devices, oropharyngeal airway, naropharyngeal airway, masks, different sizes. Okay. And this is for, I think, the advanced fiber optic and the this one, CMAC, okay, air track. These hi-fi device, among these, if you ask me, everyone can have different ideas, but in my opinion, the best is glidoscope. There is no match to glidoscope. Okay, the glidoscope is the best. Okay, just a second. Some more identification. Just a second. Actually, there was another thing which was something. Yes, this was also which I never read before. Okay, so because maybe it is with reference to the ICU management with the reference to COVID. Okay, some of the points, and they have. I just saw something here which I never saw before. Have anyone read about this? Makocha score. I'm sorry, I never read about. Just when I was searching the articles for Airway, I just found this article. Okay, Airway management in ICU. So this is also something which can be, if someone happens to have a look on such article, they can ask you. It's nothing. I don't think so. It's something difficult. But if someone asks you suddenly, you became confused. Okay, so they are asking. They are telling about some of the Malampatti. Okay, and then obstructive sleep apnea, reduced mobility of cervical spine, limited mouth opening. So, and then coma related to pathology, severe hypoxemia, and factors related to arm pressure. So, I think this is with reference to airway management in ICU. Okay, nothing special, but this is something new for me. Okay, that's why I just wanted to show you. Another I just now I came to know our question in theory MCPS. Which question, Imran? Can you
Sir,
tell me?
with respect to difficult intubation, they were asking that in a patient with rheumatoid arthritis,
Hmm,
there is a cervical spine stability. Now
hmm.
you have to identify the patient is having difficult intubation. What will be the criteria to identify? They were having four options as far as I remember. One was Cormac-Lehane grade 3 or 4. One was Malampati 3 or 4. One was one was interincisor distance of greater than 3.5 centimeter, and one was of uh, thyromental distance of 6.5 centimeter. So I was confused between Cormac Lihane grade 3 and 4 and between Malampati 3 and 4. So it was repeated basically this question, and I in one option chose Cormac Lihane, and in the second option chose Malampati grade 3 and 4. And then later on, I got to know that Malampati grade 3 and 4 is having 95% specificity for difficult intubation.
Yes. Okay. So now you understand the concept. If you these things you can only learn if you read from something accurate. Okay, so articles are accurate. Oxford, this is also written in Oxford as well, but because I remember one thing, don't think that when I was studying these articles I had never read. Okay, I don't know about them when I was in because unfortunately the world was not that much advanced, but now everything is in your access. And actually I shared this thing that I have taken this subscription for all of you, paying. I'm not telling you to just to prove something. I'm just telling you that I have paid 1000 real just this maybe 1 month ago to have subscription to have these articles. So please honor it. It's for you. If you people use it, then I think my 1000 real will be nothing. But if you don't read it, I feel disappointed. Okay. So this is I that's why I want all of you to change your perspective or of reading. Okay, rest of the things are the same. Okay, there is nothing different with reference to COVID. Do you know what is the problem in intubating a patient with COVID? In addition to the problems with reference to this one, like patient having infectious charge, forget about infectious things. Of course, you have to protect yourself. The problem is that these patients sometimes after intubation collapse because of can any one of you face after intubation patient suddenly collapse?
Sir, I have seen a lot of bone patients collapsing after intubation, and we
Yes,
have to start CPR. Even I have
CPR.
seen on table children, a pediatric patient, I guess of 3 years, he was having the bone, and the moment we intubated the patient, at that very moment the patient went into the cardiac arrest, and we immediately started the CPR, and within 2 to 3 minutes, the patient came revived. But then
Yes.
again, the mortality in the bone patient, it's really high.
Yes, actually, no, I am saying with reference to COVID. Actually, these patients are actually exhausted with so much catecholamine. Then when you give the induction agents, actually they are not able to tolerate. So now, unfortunately, we are out of that serious times. But I have seen that majority of the patients, when we give when we try to induce, actually they collapse. And sometimes people are giving suxamethonium. Suxamethonium is very dangerous in such patients. In my experience, because of again, same thing, that these patients are already exhausted. Majority of cases, they are hypoxemic. Yeah, unless they are intubated very early. Okay, if they are intubated after too much trial of many prone ventilation and CPAP, and after that you are trying to intubate, I have seen that patient collapse. Okay, so this was a interesting
So
article
same
which I
goes with the burn patients. Basically,
burn
the
patient
management,
also.
the management of pain in burn patients is really poor here.
Yes,
So they are also having the high drive basically.
yes. Okay. So this is also something which I found new here with reference to face mask ventilation, hand grading of face mask ventilation. Not attempted, ventilated by mass, ventilated adjuncts needed, ventilated difficult, two-handed adjuncts needed, impossible. I'm sorry, these things are new, but maybe they can ask you, okay? Because if, again, I tell you something that they create, especially it is true for uh, people who are appearing in FCPS, okay? Because they can find such things. And this is article of 2021, I think. Okay, so
So NAP4 is quite old audit report, because as far as I know, I guess it's NAP6 is going on right now.
no, NAP 6 actually it is not matter of NAP 4 or NAP 5 or NAP 6. NAP 4 was for airway, NAP 6 is for anaphylaxis. Different
Yes, sir.
topics. Okay, these are different
Okay, okay, okay.
topics. Okay,
Okay, sir, got
so
it.
okay, so
So that
so
is also an interesting thing, because a majority of us aren't knowing that NAPs were
no,
related
no,
to
no.
some specific
No.
topics.
NAP National Audit Project with reference to the topics, not with reference to. Okay, so these topics they can ask you in the talks as well. Okay, so you can have
Yes, sir.
with reference to LMA and IGEL. What is difference between LMA and IGEL?
Says
LMA,
is first
yes.
generation and IGEL is second generation. IGEL is having an additional block of bite blocker,
Okay,
because
what else?
sir, it is having the bite blocker, and then it is also having a fixed suction port attached to its side,
Hmm.
and the bite blocker can be detached easily, but then again it will be of no use to use the LMA without the bite blocker.
Actually,
And
IGEL, the
moreover,
difference, IGEL difference is that IGEL, the placement is relatively easier. Fixation is better. There is no problem with reference to the inflation. Okay. Because when we
yes, sir.
inflate LMA, maybe some patient will needing more, some patient will be needing less. So you are not sure. This is something. And the other thing is that it will allow higher airway pressure. Then IGEL can be used in lateral position as well. Sometimes LMA will dislodge. Okay. So there is documented that IGEL can be used in lateral position as well.
So
Okay.
here I want to explain it that we have used eye gel even in changing the positioning of the patient, especially in burn patients to whom we had to take them under anesthesia for change of dressing, because what we used to do, we used to change their dressing, then wash them, and in washing them we had to lateralize them, and sometimes we had to even keep them in lateral position, but then again we had to keep an eye over the bag, either it is
Mhm.
inflating properly and either the tidal volume is adequate or not.
Mhm.
And one
Okay.
thing more, sir,
Mm.
I have seen that Chinese are coming up with new sort of IGL, and they are having another that inflating port around the laryngeal seal.
Okay. So last question or last point before I finish is you are doing a prone position surgery. So, for example, you can say spine surgery and tube is dislodged. What will you do?
We can put IGEL.
We will put IGEL. Is this Sabah Aftab?
Yes, sir.
Okay, please Sabah, try to have a better answer. In the exam, if you will say IGEL immediately, this will be a considered a wrong. Immediately stop the surgeon. Okay, immediately if the tube is already out, you will put on face mask. Okay, you will like you attach with the mask and have manual ventilation. Okay, then you will arrange for IGEL or LMA, or you will try to put it. Okay,
Okay, sir.
understand? So our answer is correct. IGEL can be placed with the prone position, but again, in the exam point of view, you have to answer like this. Then the second part of question, this question was asked in our exam. You are not able to ventilate, you are not able to maintain the airway, and patient has cardiac arrest. What will you do? Mind it, it's prone position. Yes. Tubeless lodgement in prone position. Now there is cardiac arrest.
So we will log roll back the patient to spine position.
The spine is open. Is it easy
Oh,
job?
okay. No, sir. The
You will
spine is
start
open
the
and the.
CPR in prone position. Okay.
Okay.
And if you are failing, then if it is in the upper thoracic, maybe the the surgeon can open the thorax and have open cardiac massage. Okay. So actually, airway
What
management.
about the airway, sir? Tube is dislodged.
Mhm.
And how airway will be maintained?
Of course, is CPR. In CPR, you need to ventilate the patient. If you are able to ventilate, then you are doing good with reference to CPR.
Yes, sir, as
Okay.
you said, no ventilation, no mask ventilation, no intubation, tube is dislodged. Then how we will ventilate the patient?
No, you are absolutely right. With reference to CPR, you have to start the CPR from the prone position. Okay. And of course, you will
What about
try to
ventilation?
ventilation. Of course, you see, this is a tricky scenario. You will, because in the exam, they ask with reference to specific, because if you are handling the ventilation, the answer will be like this. Okay. And now, if you are starting having CPR, you will just try to ventilate. And of course, if it is possible, you will try to flip the patient if nothing is working. We can
Sir,
just pray
cardiac
that
arrest is due to the airway dislodgement. I think so.
yes,
Cardiac arrest is due to the airway dislodgement.
yes, you are
So, if
absolutely right.
how we will manage the airway, so this patient?
Yes, so it's a we can just pray that we never face this issue. But with reference to exam, you can say that you will try to flip the patient. You will try to have the CPR from the prone position. You will try to ventilate. Okay, real time. That's why we should have too much fixation of the tube that it never comes out. Okay, because this is not written in any book. Neither I found this point in any article. It was asked many years ago in our exam. in Irish fellowship exam. Okay, so no, you are right, Adil. I'm not saying. I'm sorry. We will try to flip the patient. I'm not saying this thing, but remember one thing: the highlight of CPR in CPR in CPR, the priority, which is the more important thing, massage. Okay, the more important thing is cardiac massage. There is a confusion. I think I did not say that you will not try to flip the patient. I'm saying that maybe it is like you will try to start the CPR first. Okay, and in the
Sir,
meantime, because it will not be very easy to flip the patient, mind it. Okay,
yes, sir.
because there is, maybe you will need to transfer the patient to the floor to have the CPR.
But sir, it's a
Okay.
do and die situation.
Yes, it's
So how we will leave the airway in this situation?
no, Saf, you are absolutely right. But I'm telling you that priority in the CPR, the priority is for compression. Okay. Of course, you in the meantime, you will try to secure the airway even. If the tube is dislodged and you are not able to ventilate and you had cardiac arrest, so it means you have to fix that problem as well. But I'm just telling you that in the exam, you have to just anticipate the answer. You will say like this. Okay. So, airway management is a big topic. Okay. I had discussed before as well. And even when I sent yesterday, I sent the link for the previous airway, because I discussed airway in detail. Too much detail. We had discussed all the even equipment, airway assessment, fiber optic, and there are so many topics which we discussed before. Okay, so you can have the discussion, inshallah. Tomorrow we will discuss some other topic. Thanks a lot, all of you, for your presence, and especially the Viva candidates. I will suggest you just keep discussing, answering the thinking, because Viva is all practice. Okay, even for MCQs, if you have the correct concept, you will be able to identify the correct answer. Okay. Okay,
No,
Saf.
sir. Thank you very much, sir.
Okay, so this was actually this document is with reference to the airway management. I will also I yesterday also I shared in the group. So airway articles are in the articles folder here, and these are the articles year wise. So actually,
Sir,
yes,
sir, there is a thing. I have just searched on Google that even in the prone position, you can intubate the patient. You
yes,
have
you
10
can.
seconds after cardiac massage. After
Mhm.
CPR, you have 10 seconds, and in that 10 seconds, you just have to, with the help of two assistants, you can raise the chest of the patient, and meanwhile, you with your own hand can intubate the patient in prone position.
Yes, someone will continue the CPR and other person team. Even they were also telling that we can even try to have with fiber optic. Okay, because fiber optic can also pass. So there are so many
Yes,
ways.
sir.
We will try to handle the situation. Okay, because you will tell that flipping is a problem. Even with the flipping, there will be a problem. Even if you don't flip, even then there will be problem. So according to the scenario, you will do it. Okay. So thank you, all of you. Inshallah, we will meet again. These I will suggest you, if you have any question, you can ask me anytime. Okay. And this is the articles are arranged in the folders, so you can have this. You will find all the topics: gynae, peds, elderly, cardiac, respiratory, all topics. And if you don't find, you can anytime you can ask me. Okay. So
Thank you, Dr.